my disclosures. So let's start with this picture. You've likely seen it before. Do you see a woman? How old is she? Those of you that see a young woman, can you raise your hand? So what if I told you you were wrong? This was actually an old woman. Can you see her now? This is from Stephen Covey's The 7 Habits of Highly Effective People, published in 2001. In that, he talks about paradigms, models, frames of reference, the maps for the way we see the world. Our attitudes and behaviors grow out of these assumptions. Now, I have a word. What do you see? What palliative care is surprisingly difficult to succinctly describe because, in contrast to other disciplines in healthcare, it is not defined by the sex of the patient. It is not defined by your age. It's not defined by where you are. What is clear, though, is that palliative care is much more than comfort in dying. So, I will ask you to consider for a moment what we cannot see. And if your mental model of palliative care is just comfort in dying, I'm going to ask you to take off these glasses for a moment. My objectives are, through examining palliative care with the questions what, why, and how, that while each of us will feel affirmed in the work that we do, we'll continue to advance access to quality palliative care services for all patients with gynecologic malignancies. So what is palliative care? There are many definitions. The lexicon is heterogeneous, and this creates challenges. The WHO definition is probably the most comprehensive, highlighting the fact that it is an approach, that it is meant to improve the quality of life, not only of our patients, but of families as well. It is life-affirming, regarding death as a normal process. It is based on a team approach, and it integrates psychological and spiritual aspects of patient care, and is applicable early in the course of illness. The CMA policy on palliative care from 2016 reviews the goals, the access of services, the educational imperative, and the role of government in advancing services. With respect to goals, they talk about a need for physicians to reduce suffering, to improve quality of life, and to value these things equally to other goals in medicine. They highlight the need for all physicians to have basic competencies in palliative care, and for some who may require enhanced skills, and this certainly applies to the gynecologic oncologist. Well, at birth, there is really only one certainty, and that's one day we're all going to die. And this truth is something many of us struggle with. So a visual model, a model to describe palliative care integration, can be a very helpful tool to explain a complex concept. And there's many models that you can use to depict an integrated approach to care, with a gradual transition from curative treatment to palliative care. If you look here, we have two overlapping triangles that intersect. You have disease management and palliative care, with the arrow running from left to right. The base of the palliative care triangle includes both death and survivorship. And the goal of this model, Pippa Hawley's model from Vancouver, is to illustrate a process in which the possibility of dying could be introduced at a time when patients and families' thoughts may be consumed with hope of cure. The contents of these triangles can be adapted. They can be individualized. And certainly, the things that are listed on these triangles are just examples. The palliative interventions that you could potentially utilize are basically too numerous to include on these slides. So obviously things like psychological, spiritual, social support, advanced care planning, music therapy, physiotherapy, whatever you're using or recommending for a patient, you can individualize and include in your model. The way forward is a national framework. It is a document and a series of other tools meant to guide healthcare players on how to adopt an integrated palliative care approach to care. It represents a 3-year collaboration between the QEL-CCC, or the Quality End of Life Care Coalition Canada, managed by Hospice Palliative Care, and supported by one-time funding by the Government of Canada. The goal is to provide a framework for the integration of care, and they discuss in the early stages of the illness what the palliative care approach should focus on, with a highlight on the importance for communication, advanced care planning, and psychosocial and spiritual support, in addition to pain and symptom management. And in the later stages, the idea that you're focusing again, after reviewing the goals of care, on ongoing psychosocial support as well as ongoing symptom management, and potentially utilization of specialist palliative care services. The Canadian Society of Palliative Care Physicians, in their document, A Call to Action in November 2016, talk about the availability of and access to palliative care being an urgent policy as well as practice imperative. And through their leadership, this message continues to gain some traction. They describe the urgency of this need, the fact that we have not yet responded to Canadian change in demography, the fact that because of a number of interventions, we're living longer, we're growing frailer, and we're dying differently. The legalization of MAID, the fact that palliative care services are under-resourced, they're simply overwhelmed, and the fact that most of the time people are not getting access to palliative services until it's very late, and they also highlight the issues with respect to cost. Only 30% of Canadians have access to palliative care in this country, and the hope is that through Bill C-277, a private member's bill, that is coming up for its third reading in roughly 2 weeks, a private members act that advocates for the development of a framework for palliative care in Canada, that all Canadians will have access to quality palliative care services. So, the Gynecology team, as we all know, has a very critical role in addressing and coordinating care for patients who will ultimately die from their disease. The symptom burden is very high, and the care model, the multidisciplinary in structure, both as the provider, a physician who's an expert in surgical and medical management of gynecologic malignancies, as a partner within this team caring for patients for diagnosis to death, means we are well positioned for an integrative palliative care approach. I included this slide to poke fun at our SGO colleagues, and maybe I shouldn't be doing that from a podium. But I thought this was quite interesting if you look at their description of a gynecologist as a captain of a patient's gynecologic cancer care team, and they describe the gynecologist as a specialist who diagnoses and treats cancers. In my opinion, they certainly could have done a better job at advertising what we're all about. So let's take a look at some of the data. So with respect to education, this is a survey published in 2013. It was done in 2009 and 2010 of fellows within American Board of Obstetrics and Gynecology certified programs. And basically what this looked like is a self-assessment of education during your fellowship program, and asked very specific questions about, during your fellowship, have you been explicitly taught certain things? And clearly you can see here we do have room for improvement. Of note in this survey, the fellows felt that palliative care was a very critical part of their training. They felt that they were not getting the palliative care training that they would need, and they also felt that their attendings did not have the same sort of priority regarding communication and other educational issues that would be part of palliative care as they did, which is an interesting finding. Here's another survey. 56% of fellows reported never receiving feedback about discussing a change of goals of care. 46% reported that they had never been observed by an attending in the first 10 end-of-life conversations focused on transitions. If you think about the complex surgeries that we perform, and the amount of time, energy, investment, when you think about the numbers of hours of supervision and feedback that you give, it's certainly hard to understand how an equally complex procedure such as discussing goals of care and discussing treatment decisions for a serious illness, which is probably one of the most complicated things that we do, it's hard to understand why there shouldn't be as much attention to this as well. This is a needs assessment of palliative care education in gyne-oncologies. It was an assessment of fellowship directors. And what this shows is that there is a large number of program directors that are reporting explicit teaching of each topic in categories like symptom management, communication, and end-of-life care. And at least 50% of programs are covering these topics, at least the majority of the time, with the exception of fatigue, delirium, and perhaps opioid rotation. The interesting thing about this report is that while the program directors report communication as being one of the most important areas for teaching fellows, the number of hours spent in the curriculum on these topics does not reflect that. There is absolutely no correlation between those two things. So early palliative care interventions. What about these interventions in oncology? So clearly there is a fair body of evidence that supports early integration. Certainly the question of when to incorporate these interventions is a major one. And the shift basically with the publication of Tamel's paper in the New England Journal in 2010. That basically was a paper, a randomized controlled trial of stage 4 non-small cell lung cancer patients who were enrolled in a palliative care intervention. They were within 8 weeks of diagnosis, and they were randomized within three weeks of that. What they did was had an outpatient palliative care consultation and then monthly visits that were done in concert with the oncology intervention. And the impact was significant. There was improved patient-reported outcomes, and very interesting, there was a prolonged overall survival of 2.7 months in this paper. Many papers support improved patient-reported outcomes, less aggressive care at the end of life, and not all support prolonged overall survival. The CSPCP, in a report in February 2017, looked at the economic evidence and summarized this by saying that in their estimation, based on that review, hospital-based palliative care could save the healthcare system between $7,000 to $8,000 per patient. So what about in gynecology? Well, there is more and more evidence in this patient population, and reports within the last couple of years support the fact that outpatient end-of-life discussions shorten hospital admissions, that early integration facilitates discontinuation of anti-cancer therapy, and potentially could be cost-effective. The SGO, in a position paper published in 2015, support early integration of palliative care, as does ASCO. So, if we want to improve our palliative care clinical acumen, how can we do this? Well, EPIC, Education in Palliative and End-of-Life Care, is a curriculum that is internationally recognized. It comes from the NCI, has been adapted for the Canadian context in something called EPIC-O, and very recently has been updated, an online platform available through the D'Souza Institute. It costs just over $500, and you can see the curriculum on the right-hand side of the screen. You can do it at any time, at your convenience. And clearly, this is a model that's accessible to all. It was designed with the interprofessional focus in mind. The virtual hospice is a great source of information. And for those of you who are interested in introducing methadone or potentially having anything to do with patients on methadone, there is a methadone course that you can access through virtual hospice. So a word about communication. Just a word, I promise. So communication is clearly a key issue in healthcare. For patients, there is so much evidence that communication really is a pillar of support for patients. It helps them adapt to the realities of the illness. It facilitates a person-centered approach. It can increase patient health outcomes and compliance and improve safety. There is evidence that it has innumerable benefits for the healthcare provider as well. So I'd like a show of hands. How many have seen the play Wit from 2001? All right, so can you play the slide? Here's an example of communication for us all.
You have cancer. Ms. Baring, you have advanced metastatic ovarian cancer.
Go on.
You are a professor, Miss Baring.
Like yourself, Dr. Kalikian.
Ah, yes. Now then, you present with a growth that unfortunately went undetected in stages 1, 2, and 3. Now it is an insidious adenocarcinoma.
Insidious?
Insidious means undetectable at an early stage.
Insidious means treacherous.
Shall I continue?
Oh, by all means.
Good. In invasive epithelial carcinoma, the most effective treatment modality is a chemotherapeutic agent. We are developing an experimental combination of drugs designed for primary site ovarian with a target specificity of stage 3 and beyond administration. Am I going too fast?
No.
You will be hospitalized as an inpatient for treatment each cycle. After the initial 8 cycles, you will have another battery of tests. The antineoplastic will inevitably affect some healthy cells, including those lining the gastrointestinal tract from the lips to the anus and the hair follicles.
Okay, we can stop the slide. Thank you.
Resolve to withstand.
So how can we get better? On behalf of the American College of Physicians High Value Care Task Force, there was a communication about serious illness care goals. This is a review and synthesis of best practice, and it's an excellent resource. All the resources that I've mentioned today are included in your syllabus. Clearly, there are deficiencies in serious illness care communication, and this can be at a patient level, physician level, and a system level. For patients, there's innumerable factors. Anxiety is a huge factor. They may expect that we're going to bring things up when we don't. The list is very long. Physicians, there's innumerable barriers as well. Systems, well, the default generally is aggressive care. I found this resource recently, and I think it's a fantastic tool that provides both learners as well as teachers guidance on improving communication in healthcare, focused on primarily the physician. The review that I cited 2 slides back gives you a framework for discussing serious illness. And on this framework, any framework generally is something that can help guide an approach and make sure that you have a foundational element to start. And then obviously it has to be tailored to the patient, the family, and the circumstances that you're dealing with. But of note, I've highlighted in red the goals. So certainly, you know, if your healthcare situation worsens, what are the most important goals you have? There are a number of different goals a patient might have, as you know, and cure is only one of them. And exploring what those goals are is certainly a part of a patient-centered approach. Bale, Breaking Bad News, in the Oncologist 2000, describes a 6-step protocol for delivering bad news. And this is a useful framework as well. The Speak Up campaign is part of a larger initiative of advanced care planning in Canada. And I have to say that this, so please look up this resource. The Conversation Guide for Discussing Goals of Care is fantastic, as is the one for advanced care planning. I have 1 minute, and so we're going to skip this video. A word about CPR. As part of this campaign, there is a cardiopulmonary resuscitation decision aid for patients and families, and this is incredibly useful. If you look at question 4, how well does CPR work? You can clearly see that for patients diagnosed with cancer, 90 out of 100 will die, and the chance of a survivor going home is very low. You can see that very easily with the diagram. At about half of survivors will need to live in an institution, and half will have problems with memory loss, attention, and getting things done. This is a very important video that my kind moderator will allow me to go over for. So can we play the video, please? This is where we're all going, and perhaps I'll end here with his kind indulgence.
I typically approach these things, first of all, by making sure I understand this patient's medical situation, their prognosis, their treatment options, and the pros and cons. Next, I make sure that I communicate with the patient and their family that this is going to be an important conversation and that the right people need to be in the room. We have to remember that 70% of human communication is nonverbal. So it's both the space around the family and the doctor, as well as the doctor's own facial expression and body language. So the first thing is to find a room which has a door that closes and is quiet. Then you arrange the chairs in a circle so people are facing each other. I always get a pitcher of ice water and some cups and some Kleenex because there's often tears and it helps people to be able to deal with that. Everyone will go around the room and introduce themselves and say what their relationship is to the patient. And secondly, I want to assure everyone that everyone will have a chance to speak and no one will be interrupted. The next step then is to ask them exactly what the other doctors have told them. And this is where you get the opportunity to hear that they've heard a lot of different things that actually don't align very well, which is unfortunately very often the case in modern medicine. This is the stage where you remember the 3 words: ask, tell, ask. And the first ask is finding out how people like to get information. And what that does is, in the 90% who say, yeah, I want all the details, they have given you permission to tell them. So you have essentially placed the power and the control over the exchange of information in the hands of the person and their family. The tell part, which we doctors think should take up the entire meeting and we spend a lot of time feeling anxious about, is actually the shortest part. The tell part is where you say, for example, I'm sorry to have to tell you this, Mrs. Jones, but the PET scan has shown progression of your cancer. And then you stop talking. Because nothing you say after that is going to be heard. It's exactly what they were afraid of hearing. You've said it, you've got to give them a couple minutes to process it. And it will be emotion. This may be when you need the Kleenex or the water. And when you've spent enough time hearing their reaction and saying, I'm sure this is really upsetting to hear, is not what you hope to hear, you then ask them to tell you back. So that's the ask, tell, ask. Mrs. Jones, sometimes I tend to use big words or language that is medical, and I just want to be sure that I've been clear. Can you explain back to me what you understood from what I said? And then people will kind of take a few minutes, and then they'll pull themselves together, and then you'll ask them to explain back, and then they'll ask you, what's the next step, doc? There are a couple of really difficult questions that doctors dread, and the first one is, doc, am I going to die of this disease? And the right answer to that question is, barring some unexpected accident, yes, this disease is what you are going to die of. You have to understand this is not going to come as a surprise to your patient or their family. They just need validation of what they already fear and know deep inside themselves. And that's when your preparation that you did before the meeting, it comes in handy, because you will be able to explain the options and their pros and cons and how you're going to help them figure out what the best path for them is in whatever time they have remaining. A very important step that I think is often missed by busy doctors is to write down what we said.
I'll have the next
and
slide,
also
please.
When you are next going to see them. and
Didn't she
how
do an
they can
amazing
reach you.
job explaining what to do? She did so much more eloquently than I ever could. Don't worry if you're not there. A force field analysis can help you identify sort of where you are and examine the driving forces and restraining forces that may be keeping you from getting where you want to be. And provides a framework for looking at the people, resources, attitudes, traditions, values, needs, and regulations that might prevent you from getting where you need to be. So I'm going to end with my conclusions. Thank you for your attention. The principles of palliative care are a critical element to quality health care for all of us. They're a critical component of a holistic approach for teams caring for patients with gynecologic malignancies, and they can be learned. And the benefits to patients, healthcare teams, and the economics make it an imperative, not only in gynecologic oncology, but in the rest of healthcare. Thank you.
So, Shaundra, that was excellent. As a kind moderator, I'll allow a few questions if anyone has one. I have a question. So, if do you have any advice for a physician who has maybe drunk the Kool-Aid that you're presenting here and does involve early or involve palliation early on in the care of a patient? Do you have any advice though for a physician who's working in a group practice where maybe a member of that group of physicians doesn't involve palliation early on in the game?
That's a really good question. Certainly, I think it depends on your perspective, right? Are you just drinking the Kool-Aid, or do you truly believe that there is a role to play for early integration? I mean, certainly there are unanswered questions, and the question of where, who, and which patient population have yet to be answered. There's increasing evidence for early integration, but if obviously you have to carefully reflect on that data and make a decision about whether or not you feel there's the evidence base to support that. I certainly think you can make an argument for introducing the vernacular of palliative early within the patient care kind of map, right? So a lot of evidence that sort of introducing the concept can help address some of the stigma with the word palliative care and start the journey of sort of further exploring what palliative care is for the patient. So on a patient level, that would be my suggestion. And within the context of a group practice, I mean, obviously, you function as a team, an open, honest discussion, further exploring what the hesitations are and how to potentially push the agenda forward, which I think is valuable. A valuable investment of time.
Okay, thank you.
Thank you.
We'll take one more question.
Dr. Robinson.
Hello, Dr. Popowich. Thank you very much for that. Some good tips and some good resources to help with communication, because I think a lot of us do find it really challenging. My question for you is, I hope this doesn't put you on the spot, but do you have any tips or any suggestions about those patients who are refusing to have these kinds of conversations and not willing to discuss it? Because we often do come across that patient population as well.
That's a really good question. No, it doesn't put me on the spot. Talking about communication is a really humbling experience because certainly, I'm not an expert, and I really am hoping that I haven't sounded like I'm trying to be one. It's difficult. It's really difficult. Probably the most important thing is to respect where the patient is at. So I'll give you an example. When it comes to advanced care planning, at Cancer Care Manitoba, they've recently started this initiative, and so the question given to the patient is, would you be interested in hearing more about advanced care planning? And so patients can tick no. I think probably one of the most important things is to explore that a little bit, and to find out what it is that the patient, why the patient doesn't want to discuss that. And then education. So the reason that we do advanced care planning is to help ensure that every person has a say in what happens to them at the time if you are too sick to speak for yourself, and talk about a healthcare proxy or substitute decision maker and the importance of doing that, and then give them some written information. The most important part of advanced care planning is actually the reflection and the communication with your family. And a lot of people don't know how to start that conversation. So sometimes that can be enough to help the patient move forward, and then following up on that. So I think the take-home message is don't push a patient that isn't ready, because it's really okay to be where you're at. You know where the patient's at, and that's the most important thing. And then give the patient the tools to explore should they find themselves in a place where they're ready to do so. Thanks for your question.
Okay.
Jake, I know you don't have comment. I just want to comment. Thank you, Shauna. Excellent. And I think that I did drink the Kool-Aid, and early integration has been proven in palliative care and in oncology, in all kinds, to actually improve overall survival in some studies. And if nobody's read the book Being Mortal by Atul Gawande, it's an excellent book that everybody actually, and even oncologists should read. And there's a lot of information in that just about care of elders, as well as how we as doctors don't have good training in introducing palliative care early, but it does make a difference. So
thank you for